Tonight's Dialogue with Doctors focus is confessions of a fibroid sufferer, hidden symptoms such as frequent urination, fertility challenges, urinary incontinence, mood swings, and constipation. We have a great lineup for you tonight of doctors and a patient advocate. So I want to introduce you to them. First is Dr. Tiffanny Jones. She is an OBGYN and she specializes in reproductive endocrinology based in Irving, Texas. Now she has clinical expertise in all aspects of the diagnosis and management of infertility. And she understands the emotional investment of couples undergoing fertility treatments and stands with her patients while striving to give the best care to the couples for their quality of life and those who are seeking fertility treatment. So Dr. Jones, thank you so much for joining us tonight. We are looking forward to you sharing your expertise.
Thank you so much for having me.
Of course. Okay, next up is Dr. Shyama Matthews. She is a board-certified gynecologist, and her particular interests include the management of endometriosis, fibroids, chronic pelvic pain, and menopause. Now, in listening to her patients' fears and concerns, she strives to find the treatment plan that is best suited to their individual needs. Dr. Matthews, great to have you tonight. Thank you for joining us.
It's great to be here. Thanks, ladies, for having me as well.
Now we have our patient advocate, Rosco Spears. She is a creative director and self-taught visual artist from the west side of Detroit, Motor City. And when time allows, Rosco spends her days working with children. She holds a master's degree in criminal justice administration with an emphasis on juvenile justice. Now, while creative directing and teaching over the past 8 years, she has suffered with fibroids and is now using her voice and story to raise awareness about this very prevalent condition. So Rosco, great to have you with us tonight. Thank you for sharing your expertise. We appreciate it.
Thank you for having me. I'm happy to be here.
Great. Okay, so I want to start with Rosco. Talk about your diagnosis, the journey you went through finding out that you had a women's health issue and what that issue is.
Yeah, so my journey started around 2011. I'm sure like many of us, I was just experiencing really heavy bleeding, very bad cramping. I went to a couple of doctors and they're like, you're just a heavy bleeder. You just have heavy periods. It's okay. Kind of just deal with it. It wasn't until I moved to New York in 2012 where I saw a different doctor and she's like, girl, you got fibroids. Like she knew off the bat. So she put me on a birth control. That birth control, it takes birth control a really long time to regulate your cycle. So at that time, I didn't realize that. And I was like, what I'm not about to do is bleed for 2 months straight. So I just stopped taking it. But then I eventually signed up to get surgery for 2013. So in 2013, I had my first abdominal myomectomy, which is essentially like a C-section scar across your lower abdomen. They removed 16 fibroids.
Wow.
And I was good for about 2.5, 3 years. And during that time, like before my surgery, I was bleeding to the point where I would almost pass out. I had to get blood transfusions. My hemoglobin was at like a 5. But I finally had the surgery. I felt better for a few years. And then I realized again that my bleeding had picked up. Like the clots were ginormous, like no pad could hold the size clots that I was pouring out, because I don't know who all clots on the line, but if one blood clot falls into your panties or into your pad, like the size that mine were, they'll just spill over on the sides. So it got to the point where I was taking like 6 iron supplements a day to try and keep my hemoglobin up. I would have to carry a change of clothes to work because I knew by the time I commuted, you know, my hour commute, I would probably spill over and ruin my pants. So I had to, first of all, pay my rent, but I also had to make sure that I didn't look crazy once I got to work. But I feel like I have so much to say. I'm trying to figure out what I want to share. But I just got married almost 2 weeks ago. And when I was talking with doctors, they were saying, if you plan to get pregnant soon, you should hold off on getting another surgery. So for the past 1.5 years, I was on norethindrone, which is another birth control supplement that suppresses your period or regulates it. So once I started taking Norethindrone, I knew that I would bleed for a long period of time, but I didn't know that it would be about 15 months. So literally every day for about 15 months, I bled every single day. Now, it wasn't the heavy bleeding. It was lighter bleeding or spotting, but I think that I had post-traumatic stress disorder. So I would still wear pads because you never know when your body's going to start clotting, and you always want to be prepared. So I got off of the birth control the day of my surgery, which was August 6th. This last month, I had my second surgery. They removed 80% of the fibroids, which were 51 in total. The rest of them, the surgeon couldn't get to because he said that they were just in areas that would damage my body if he were to try to get them. So now I feel a whole lot better. I feel like I'm fully recovered. I'm trying to be responsible and not work out and go for a run and really listen to my body, because my husband and I will start trying to have a baby soon. I go back to see my doctor in November, and that's when he'll let me know what's happening all up inside my body. But that's the gist.
Yeah, that's a lot. That is
Yeah.
a lot. So heavy bleeding, was that your main symptom, or were there, in hindsight, were there other things happening that you can now identify and say, that was because of the fibroids?
Yeah, I mean, mostly just the heavy bleeding and the cramping. And it really depends on the day when I decide which one is worse. Like sometimes if I'm not bleeding as much, but the cramps are very intense, it would be like, okay, these cramps are really killing me. But some days the bleeding all over myself in public is what's most important at the moment. So it's like, I can deal with the cramps, God, but please just let me stop bleeding.
Yeah.
So both of those things. And then, I mean, it just causes a lot of anxiety and stress. I think it's difficult for me to say that I was depressed, but I probably did go through a segment of depression, just dealing with my body and not wanting to leave the house, not really knowing how to handle all of my symptoms, not knowing who to talk to. It just weighs on you mentally and physically, of course.
Yeah. Well, you said you probably had PTSD, and I completely understand that. I mean,
Yeah.
that makes perfect sense. And you mentioned the mental aspects of it. It does take a mental toll because it seems to be your body that you can't control or get ahead of it or fix. So I want to bring the doctors in right now. Rosco mentioned the heavy bleeding and the cramping was a problem for her. That seems to be kind of the most common symptom.
Yeah, most patients, that's what they're presenting with commonly, especially with the locations of the fibroid. It seems like Roscoe's fibroid burden was tremendous, to have 16 removed at one time and then another 51 a second surgery. I would only assume that they were in all different locations, and the closer they are to the cavity, the heavy bleeding is a leading symptom. But when you have so many fibroids, the uterus really can't contract the way it should to stop bleeding from blood vessels that traverse the muscle. So just like when you're pregnant, you have these contractions that help deliver a baby. When you're having your period, some of us experience those cramps, we can sense them. And what that mechanism is it's a contractile muscle that is clamping down on blood vessels. And so if it doesn't happen, because all these fibroids are in spaces where there's not a lot of muscle, then you're going to have this bleeding.
And then Dr. Matthews, when you see these patients that typically have fibroids, what are some of the common symptoms that you hear?
So I would say bleeding and heavy or painful, severe cramping is probably, yes, top 1 and 2. Other things that I'm sort of paying attention to are kind of those hidden symptoms that you mentioned, particularly related to the size and what I call bulk of the uterus, or bulk symptoms that may not be really related to bleeding or pain, but they could be related to how those fibroids, how that uterine size is now influencing the surrounding organs, right? So for example, pressure on the bladder. So feeling like you can't hold your urine for very long, you got to run to the bathroom every time you go, small amount comes out, different positional things. Sometimes you have to kind of shift position to kind of feel like you fully emptied, waking up a lot at night. Sometimes other kinds of things like with constipation or diarrhea, like symptoms related to the bowel because of the way that the uterus is compressing the intestines, and how the stool kind of passes through the intestines and exits. So not being able to go regularly, or when you go, having to strain, again, positional kind of things. I've had women tell me that, you know, they have bleeding, sure, they have heavy bleeding, cyclic bleeding, prolonged periods, but then they also get bleeding when they try to work out, when they try to have sex, like anything that provokes or you know, jostles the uterus a bit, will shake, and basically shake loose, you know, bleeding that all of a sudden spontaneously occurs. So you can understand how this starts affecting your day-to-day. You stop doing the things you love, stop going to the places you like, you know, stop enjoying the activities that you do. When you go out to dinner, you have to worry about all of these other kinds of things. You know, when you want to hang out with your girlfriends, like, you have to worry about, like you said, bringing a change of clothes just to get to a day of work, just to get through your commute. I mean, you see how all of these things kind of start influencing that. So,
and really affecting the quality of life. I'm
correct.
curious, doctors, when you see women come into your office, what are the common complaints? Do they ever say, like, you know, I'm having a hard time holding my urine, or is it more like, oh, I'm bleeding through my clothes? At what point do they kind of realize, okay, this is a problem? Like, what's the symptom that triggers the doctor's appointment?
I would say bleeding most of the time is the trigger, because it's something that most people will sense as abnormal. We don't really talk about our periods, so what's normal to me may not be normal to you. But, you know, like if you're, you know, bleeding and staining through your clothes, like those things just kind of ring more like something's going on, something's wrong. Just the sheer amount of pads and tampons you're having to use every month is like, well, this can't be right. But I think that some of the more subtle symptoms I have to tease out of people.
Right.
You know, you
Mm-hmm.
really, it just flies under the radar. Right. If I ask somebody, you know, like, do you have a frequency of urination? It's like, well, what does that even mean? You know, but like, do you know that you're supposed to be able to sleep through the whole night without having to go to the bathroom? Do you know that if you drink a bottle of water, you shouldn't have to go like 30 minutes later to go pee? Or do you know that, you know, like your bladder should be able to expand more and hold more? Or, you know, your stools, it shouldn't be pencil-like. They shouldn't be little, you know, small pellets. Like, you know, like these things, like you just, like, they're not as bothersome, or, you know, it just is, you're not thinking about them, you know, or it just doesn't, it's not as scary as bleeding to death, you know? So I have to ask those questions. I don't think, or use a questionnaire to get that information.
Mm-hmm.
People tend not to come to me for that, those subtle things.
Yeah, and I can say, you know, in my experience, I had a myomectomy several years ago, and I had 10 fibroids removed, and I'm pretty much was asymptomatic. My doctor found it because I went to an annual exam and I laid on the table, and she was like, your uterus is enlarged. And I say all the time, you know, I'd hit 30 and I thought maybe my metabolism slowed down and I was just gaining weight. And she was like, no, that's definitely something in there. It's hard. Like, you can't crunch your way out of it. And so, yeah, I ended up having 10 fibroids removed. I would have never thought to track, you know, my bowel movements, what they look like or how they felt, or, you know, having to use the restroom at all. Is there just a lack of education out there in terms of women's health in general and what women should be on the lookout for?
I think so. And I think partly women will put up with a lot.
Yes.
Like, you'll let things slide until you're basically dropping from this problem, right? Even the bleeding. Like, I'll have patients come in and be like, oh yeah, you know, I just take an extra iron tablet. Yeah, I felt a little tired, but I mean, I've been soaking through pads for the last 3 days. You know, I can barely like leave my house, but that's okay. It'll be fine after a day. And that's not okay. That's not normal, right? And I mean, the spectrum of normal is wide, but what women will put up with in order to be able to do everything they're trying to do, get to their jobs, take care of their families, you know, take care of their homes, whatever it is, their careers, their school, like they'll put through it all. And so that's part of it, is that they'll wait until something is unsustainable. So you have to, as physicians, I think it's on us a little bit to tease it out. We have to ask the right questions. We have to make sure it becomes part of our routine conversation. And then also paying attention to some of the more subtle signs, like you said. Like, I mean, as far as, you know, many women don't think about their bowel symptoms or urinary symptoms being related to their GYN. Like, they just don't, right? Why would you associate the two? But when you're talking about organs that are sitting right up against each other, there are many different uterine conditions that influence, you know, your bowel movements and your urinary habits and things like that too. So you're right, no one thinks to track those things, but when someone starts asking those questions, then you might be able to put 2 and 2 together. A very common thing as well, like you mentioned, it felt like it was just weight gain, or maybe I let myself go a little bit, or I've hit 40 or 30 or whatever age, and you know, not really being cognizant of it, or not really being aware that that's like not a normal change of the body, or you know, an acceptable change. And again, same thing, like a physician being able to kind of catch that. So I think a couple of things would be just people kind of taking note, maybe really taking time to maybe review some of the things that they've been experiencing, and nothing's off the table. So when you come in for your annual visit, just be like, listen, I don't know if any of this stuff is related, but here are some of the things that have been bothering me about my GYN, GI, gastrointestinal, my intestinal stuff, and urinary issues that, you know, that have been going on. Do you think it's potentially at all, you know, related or have anything to do with it? I mean, I think people are shy about asking some of these questions. And I think other times, you know, they think like, oh, it's a stupid question. She's going to think, you know, poorly of me, or like look down on me, or dismiss it, which I think is also, again, a fault of some physicians doing that. But I think it's, you know, advocating for yourself to some degree as a patient. And then I do think on us as physicians, you know, we should be open to what our patients are trying to relate to us. And then also asking those questions to get a little bit more info.
That's
So
to
Ross,
say
go
one
ahead.
more comment. I think also people are scared, you know, like, you know, if you feel a growth or feel, you know, like you just might think it's cancer, you know, you just want to like not deal with it. I think a lot of times it's just, you know, you just want to kind of, I'm still alive, I'm still kicking, and we just try to avoid as much as we can when you don't want any bad news, which an education really has to be that, you know, fibroids are very, very common, you know, and even for doctors, like we learn that, but it's crazy to me how many patients I see coming from other doctors, you know, because I'm a subspecialist and I do an ultrasound because it's part of my workup. And they got so many fibroids. I'm like, how did this get missed? And it's like, oh, well, my doctor like they've done an exam, a pap smear is not going to find it. And even a bimanual sometimes, you know, when you feel on someone's belly, if someone's bigger or if the fibroid's just in a place where you're not going to feel it, you're going to miss those things. Even if patients have symptoms, just like I think Roscoe said, you know, she had heavy periods and they still didn't really get to the fibroids until she went to somewhere else. It's like, well, an ultrasound was never done.
Mhm.
Right. Roscoe, I'm curious, just listening to the doctors talk about the urination and the GI issues. You didn't experience any of that.
I cannot remember the last time I've slept a whole night all the way through. But like they said, I never would have thought that that had anything to do with fibroids.
Right.
You know, I'm like, maybe I drank water too late at night. My bad.
Right.
I had no idea. I'm learning so much right now.
Right. And then I agree with you in terms of what makes you most uncomfortable or what most
Yeah.
disturbs your quality of life. Bleeding through your clothes in public is the number one thing that I'm focusing on. And using the bathroom at night, I'll
That's
just.
easy peasy compared to bleeding on yourself in public.
Exactly. Easy
Yeah.
peasy. So we do have a question coming into the chat right now. Is heavy discharge a hidden symptom? I've noticed that I have a heavier discharge a week prior to my period.
I think that would be a harder thing to really say is attributed to fibroids. So something like having like if you had a special procedure, like a uterine artery embolization or some kind of an ablative procedure, some people do have really heavy discharge after that because the fibroid is sloughing off. But that is something that wouldn't be cyclic, right? So when we're talking about like a cyclic change, that's more hormonal. Our discharge definitely does change throughout the menstrual cycle to kind of prepare us to be receptive to get pregnant. It's not to be dismissive of that, but I think it would be very hard for me to kind of see like a pathway to having a cyclic change in my discharge, especially if it's white or thick and clear, just kind of like a normal physiologic discharge. Why it would change. Your pH changes. There could be a lot of things. I don't know personally about a fibroid doing that, but.
Mm-hmm. Mm-hmm. So we have another question right now. What are some of the more common symptoms of the anemia that can accompany fibroids, and how serious can they be? And to kind of piggyback on that, do either of you ever have women come into your office and just say, like, I'm exhausted all the time? Or do we just accept that we are tired all the time?
Right. I mean, that's a common one. I mean, I think almost every woman to some degree will admit that they're tired, right? But the degree of that, and sometimes you have to listen to that a little closer and be like, all right, well, what are your periods like? Like, you know, how much are you bleeding? Like what, you know, let's talk about that a little bit more. Let's dive into that. Is that fatigue? Like, is that around your cycle? Is that, you know, because you're bleeding for 7 days and like going through packs of pads or tampons? You know, is it related to that? Some of the more common symptoms of anemia that I see, fatigue is definitely up there. Feeling faint. Sometimes I've had women tell me, you know, they going up the stairs in their house, they get a little dizzy, you know, that they feel weak at certain points of their cycle as well, especially if they're passing those big clots and things like that. Sometimes people will say they, you know, they chewing ice or like, you know, feeling like they're craving certain things. Those can be symptoms of anemia. And how serious can it can be incredibly serious. And again, this is something that's interesting about women. Like Roscoe, you were walking around at a 5, right? Like that's incredibly low as far as what hemoglobin should be.
I've been at
And
a
that's
3.
the thing. What's that?
I've been at a 3, and I still have been.
I don't
Right,
even like.
what are you doing today? What's going on?
That to me is insane.
Doctor,
So
you have
you
me quit
know,
my job.
I mean, we compensate. We compensate. We can actually sort of like, you know, subsist, and women will do it. We'll subsist at that level until we literally drop. You know, and so sometimes I scare women into this. I'm like, listen, you're walking around at a 5. If that ends up at a 4.8, that might be you passed out and being brought to an emergency room. You don't know how much reserve you have, how much it's going to take for you to, you know, top out. And then, you know, so yeah, it can be incredibly serious. Blood transfusions, you know, emergency surgery, lots of other complications associated with the anemia and the blood loss.
So I know that fertility for some women, fibroids can affect that and interfere with that. At what point, you know, if you've been trying for X number of months or X number of years, and let's say that maybe you're asymptomatic when it comes to fibroids, at what point, you know, as doctors, do you say, okay, let's go ahead and get this full workup done and check for fibroids, endometriosis, PCOS, et cetera?
Yeah, so we base a workup on infertility based on age. So if someone's less than 35, then we generally say it can take up to a year. It shouldn't really take too much longer than that before we really say something is going on, get a workup. If you're less than 35, we only recommend 6 months because fertility starts to decrease. You know, waiting longer might be taking away some really important time that could go towards, you know, better outcomes if you start treatment sooner. But this is the caveat, right? If there's something that we know is wrong, you don't wait, right? Mm-hmm. So if someone is asymptomatic, of course they're going to try and they're not going to know. And I get those women, and lo and behold, there's these, you know, these fibroids that have been there. I said my workup always includes an ultrasound because the uterus holds the baby. So I need to make sure that that is not one of the problems. I check the ovaries because they hold the eggs. I check the fallopian tubes because that's how things are transported in. And I check the sperm because that's the other half of the baby. So it always has to start there. What baffles me, and it's our fault as a medical community that it's not part of our standard workup. You know, if your doctor doesn't even have an ultrasound in their office and you're a gynecologist and we're telling you 9 out of 10, you know, women by the age of this will have fibroids, why the hell is it even part of the standard workup? You know, it's like, oh, well, if it's not bothering you, then you shouldn't even check. But it's like, now you have 51 fibroids and the only course of action is surgery, you know? So I think we have to kind of change that narrative as young doctors to kind of understand that we could probably be a little bit more preventive in this. But as far as fertility, I I have to start with that as part of my workup. But typically I tell patients, if they don't have very many fibroids, it's likely not going to be a problem as long as the fibroids aren't on the inside of the uterus where an embryo would implant. I have my little models because I feel like we talk and it's like people don't really know what we're talking about. So I'm going to show you my little model. I'm very proud of my model because I just got
Bring out the uterus and the vagina. Let's see it.
This is Yudi, okay? Say hi, Yudi. Okay? This is how a uterus should look, and this is if we cut your body straight down like this, okay? So if you see the pink part of Yudi in the inside, that's where an embryo would implant. So of course, if a fibroid is in there, then there's going to be less space. It can be having different things that are secreted that may be causing failure to implant. It could be blocking a fallopian tube. There's a lot of reasons why this has to come out. Even if it's asymptomatic, if we find this, I recommend taking it out. I don't care the size of it, I take it out. If it's somewhere in the muscle, so this red portion is the muscle, typically it's not going to cause a problem. Though I will say, if you have something that's 12 centimeters, this is probably going to go ahead. You have infertility, it's probably causing a problem. So it's more likely it's going to need to come out. But it's called a submucosal fibroid. So there are 3 parts of the uterus: the submucosal part, the myometrial part, which is the muscle, and then the subserosal, which is kind of like the skin lining of the uterus. So the only part that's really, really important that we all agree on is the submucosal fibroids that have to come out for fertility. And the rest of them, it's really kind of hit or miss about what's going on and symptoms, how large, how many, that we say we have to move forward with treatment.
So I'll just kind of dive in here and talk about, my situation. So I was diagnosed with 3 fibroids per an ultrasound. And that OBGYN was like, well, they're not really affecting your quality of life. You shouldn't have an issue getting pregnant. So we'll just wait and see. My mom is a doctor and she said, go to a fertility specialist and get a second opinion, and one in which your fertility is preserved. That's their goal. So I went to a fertility specialist and she said, what are we waiting and seeing for? They're not going to disappear. They're not going to shrink. Like, take them out. One of them was 8 by 10 by 11 centimeters. She was like, you don't want to be pregnant with that in you. Now, I did
and
not.
Look how small you are.
Right, exactly. Could you imagine 2 giant babies?
2 babies.
Yeah. So, the MRI showed 6, and then I ultimately had 10 fibroids taken out. Now, I did not have any on the inside of the cavity, so I got lucky there. But I remember the word like pedunculated and the sub, whatever you said. And so she decided to just take all of those out. Now, I still had what's called unexplained infertility. I have no idea if that would have been the case, whether I had fibroids or not. But do you ever find post-surgery, a myomectomy, that, infertility becomes an issue?
Yeah, so I kind of mentioned all the aspects, or most of the aspects that contribute to infertility: eggs and sperm, uterus, fallopian tubes. So sometimes it's not just one thing, it can be multiple things contributing. Unexplained infertility is super frustrating because it kind of means everything is perfect, but we still can't get pregnant naturally, which isn't very helpful for people who are spending money on workups and then, banking on treatment to help them when everyone's telling you everything is fine. What also people have to understand is when you have that many fibroids removed, you do still want to reassess the cavity. When you take out submucosal fibroids, you have potentially injured the lining of the uterus, which is very important for embryo implantation. We don't know all of the molecular and microscopic things that happen with this magic that is creating a life, right? But when things are not intact and things are broken, then we can understand how it can't happen. So when I take out a submucosal fibroid, sometimes I do go back to make sure there's no scarring that's left behind from that lining healing itself. Or was one fibroid really close to a fallopian tube, and now a fallopian tube was damaged where it wasn't maybe before, but now it's harder. You know, now you have 10 fibroids removed, now you have all these incisions in the uterus. Like, how do we know this hasn't disrupted something that, you know, we just haven't come across that being a mechanism yet, because science is so new in the field. So a lot of things can happen after a myomectomy that maybe we don't know or had been going on, and we just focused on the fibroids at first. And then, you know, like a science project, you take away one factor and then try to move on, and then you say, well, no, it's still not working, so maybe there's something else.
Yeah. So another question for you coming into the chat: what are the causes for embryos not to implant when there are no fibroids in the uterine cavity?
Yeah, there are, like I said, there's a lot of magic that goes into fertility. You know, I can do so much, but there are just so many things we don't know on a molecular level. There are receptors, progesterone, hormonal balances, like all these things have to be perfect. And you wonder how any of us have ever even gotten here, by just how this cascade of things just happen perfectly at once. So when I do IVF and I implant an embryo, the number one reason that an embryo doesn't implant is if it's not genetically normal. Okay, so if we don't know, if it's not tested, that would be one of the reasons. Hormonal, we give progesterone during a pregnancy or even up to implantation. There's a very delicate balance of timing. Sometimes that timing is off. There's a tremendous amount of things that could be wrong. If people have endometriosis, the inflammation could be high, and that could be a barrier to implantation. There's a lot of things that can happen.
I mean, I completely agree with you when you called it magic. When I had to see my IVF doctor, and he went step by step, like 16 steps later of what it takes to create an embryo. I mean, it truly is a miracle. It's just absolutely amazing. And you're right, I don't know how any of us are here. And it boggles my mind, and I always chuckle, because when I went through sex ed in maybe 6th or 7th grade, I literally thought that if like sperm got within an inch of you, oh,
Yeah,
you were being knocked up, you know.
And at 16, that's true. Tell the kids it's true.
35 years later,
Not so true.
so true at all. So I do, you know, also part of my experience when in terms of deciding whether to have a myomectomy, the fertility doctor told me that there is a chance, if I were to get pregnant with some of these fibroids in me, that the blood vessels could stop feeding the fibroids and, you know, go to my baby, which is great. But then now I have this necrotizing tumor in my body. Have you seen that happen?
Yeah, I've seen that for sure. I don't do obstetrics now where I take care of pregnancies, but definitely, you know, having talked to my patients who've had fibroids and also dealing with labor and delivery when I was in my training, it was pretty amazing actually, because you're right, exactly what happens. The blood supply diverts and it goes preferentially to the fetus. And so then you have this, you know, fibroid that had all of this blood vessel going to it, feeding it, growing it all these years, and now it's not getting half of its food supply. So what does it do? It starts degenerating. It starts breaking down on the inside. I've had patients come, you know, as early as, you know, a few weeks, talking about cramps or pain because that fibroid tissue is dying. So they can have, you know, very severe pain in their pregnancy. They're limited by what they can take for pain. And that even at certain times, especially with larger fibroids, at certain stages of the pregnancy can actually cause uterine contractions and potentially lead to either a threatened preterm labor, meaning early delivery, or an actual early delivery because the uterus starts contracting as a result. The tricky part is I don't think we really have good data to say, oh, a fibroid of this size is going to give you that result versus a fibroid of that size. So we don't really have a cutoff that says, okay, it's 5 centimeters, it has to come out because it's going to lead to, you know, preterm labor and complications of the pregnancy, or 8 to 10 centimeters. I mean, that's kind of when we get to those numbers that we sort of have to make a decision, kind of like you did about what's, you know, what's the right choice. Do I take the chance of getting the myomectomy done first, or do I go forward with, you know, trying to get pregnant on my own? which gets kind of tricky. But I do bring these things up with patients as well when they're having that conversation, like, do I have to address it? I mean, when you're talking about 8, 10, 12 centimeters, maybe that's a little bit more obvious to get it out of the way and not, allow that to happen. But some of the ones are, around, like I said, 4, 5, 6 centimeters. They can also change in size. They can get bigger in the pregnancy because of the hormone changes, besides just degenerating as well. And then also cause trouble with how the baby is positioned in the uterus, whether it's going to be head down and allow you to have a vaginal delivery versus, even be able to successfully have a vaginal delivery as far as exit the body, if it's blocking the cervix or, the way it would exit in the correct position.
So would there ever really be a situation or a time where you as doctors would advise, I guess, getting pregnant with fibroids or not trying to treat the fibroids, be it surgery, before getting pregnant? It just sounds like, to me, it would just be a little bit more risky to carry these extra tumors around, while you're trying to take care of and grow a baby.
I think what Tiffany had pointed out earlier about the position is really important, because if it's not pushing in on the lining, like, remember you had mentioned pedunculated. What that means is it's growing on a stalk outside the surface of the uterus, like off that subserosal. That's not necessarily going to affect so much the growth of the baby or the growth of the, of the actual progression of the labor necessarily. Could it degenerate? Yes. Again, now we're talking about sizes, whatnot. And then again, that size, I think, is also really important too. If it's not in the cavity, you might have a couple of little pebbles in the muscle that might not necessarily change your pregnancy outcome. I've seen women get pregnant with some pretty amazing number of fibroids and actually have uneventful pregnancies. Like, that's the other side of the coin, right? So you have to, because we don't have data, like we don't have research that says, like I said, specifically this number of fibroids, this size of fibroids, things like that, that specifically dictate, yes, you must have a myomectomy before you proceed. Sometimes you have to kind of come to a personalized decision. And a lot of the other factors that Tiffany mentioned, like size, location, age, other factors. Is there endometriosis involved? Is there, PCOS involved? Other kind of fertility concerns involved as well. You kind of have to have an individualized kind of discussion with your patient about it.
We have another question, and this is one that I always joke with my husband about, because we did IVF, and I say, I have a daughter now who just turned a year. I tell him, I say, as soon as she gets her period, I am going to freeze her eggs, because I don't want her to have to go through, what I went through at 34, 35 years old. And, you're sitting there praying like, oh, please develop an embryo, and et cetera, et cetera. So do you recommend that women with fibroids freeze their eggs, or does that depend mostly on an age?
I think that freezing your eggs is a personal choice. So it can be an expensive process. I think that it's not, I don't think everyone has to freeze their eggs. I think that it's great if you can, and if you do, that I think that's fine. But I don't want it to seem like women who can't afford it should do it, or you're going to lose out on everything. The truth is, we don't know if you're ever going to be infertile, and a lot of people have not come back to use their eggs. So when people want to freeze their eggs, it's because they kind of want this like extra reassurance, and hopefully you never need them. But when we talk about fibroids, if I do have a patient who has fibroids, what I do tell them is, if you want to freeze your eggs, I would try to freeze them before I take out the fibroids. And the reason I say that is because these are very complex surgeries. They're major surgeries. And, luckily you guys had surgeries that went beautifully, even removing 51 fibroids. But there are times when someone removes the entire uterus because a patient is bleeding. And then, who knows if an ovary goes too. So just to mitigate that risk, I say try to do it before you do a myomectomy. Sometimes I can't reach the ovaries when the uterus is just so big. The fibroids are the ovaries are displaced. And so then in that situation, we might have to do a surgery before. The other reason I tell patients that are thinking about freezing their eggs to do the myomectomy after that is because the blood supply to the uterus and the blood supply to the ovaries are shared. So we don't know if the ovarian reserve or the eggs will be as plentiful after a myomectomy. I know what things are before a myomectomy, but there's definitely research that shows in some patients there's a transient decrease, but if you're older, we don't know if transient is going to lead to, you know, early menopause. And I'm in a doctor's group where a doctor was like, my 35-year-old patient, I did a myomectomy and she hasn't had her period yet, and I did her FSH, it's 110, this can't be right. It's like, girl, it's right. And she's in menopause now, and we can't reverse that. So, I try not to fear monger people. There are anecdotal things. We don't know what is gonna happen. So I don't want people to think I have to freeze my eggs, all is lost. But I think really what anybody should have is information to educate yourself to make the right decision for you, right? And so if freezing your eggs is the right decision for you, then do it. If it's not, that's okay. But just knowing that there are some risks with myomectomies that, we can't foresee, but you should be told about before you undergo it.
Mm-hmm, absolutely. We have another question. Is it always suggested to have a C-section post-abdominal myomectomy instead of a natural birth? Now, I can say for me, my surgeon did the myomectomy. She was like, C-sections, period.
Same.
And even after I had my daughter via C-section, my doctor was like, so number 2, C-section. I was like, no VBAC, no VBAC.
Right.
And my explanation, the explanation given to me was, you've already had trauma on your uterus with the myomectomy, then the first C-section, why, try a VBAC. But your thoughts?
So again, I often will say it's going to be up to your obstetrician, the person who is in charge of doing your delivery. But if I'm doing your myomectomy, I'm going to tell you exactly like your doctor did, how is your, what would my recommendation be based on what kind of fibroid surgery we just did, right? So again, if you're plucking off these pedunculated fibroids on the outside and the uterine muscle is intact, then probably not, a given. That might be okay. If you're just taking off one big fibroid on a stalk, the entire muscle of the uterus is, basically intact and not scarred or not damaged in any way, that's okay. You could probably have a natural birth. But if you're taking an 10 centimeter fibroid out of the muscle of the uterus, this is now creating a defect that is now being repaired, right? Compared to when you have a C-section and you're allowed to VBAC, it's not a controlled incision along a certain specific segment of the uterus that then appropriately heals. And then after the fact that even then there is somewhat of a risk, but it's less of a risk when you VBAC compared to a myomectomy scar, which can be in multiple different planes, multiple different directions. You can have multiple different approaches. 51 fibroids, how many different cuts into the uterus did that entail? That didn't necessarily come out of all one incision, right? The way a baby comes out of one C-section incision. So it definitely causes defects and then scars, and all of those points of scar can then become put on extra tension during, those very strong contractions of labor. And so you don't want to test that, because what's the ultimate scary kind of outcome is uterine rupture. One of those scars unfortunately opens up during labor, and now you're having an emergency situation where mom and baby are at risk. No one wants that. So yes, I typically say if it's an intramural muscular fibroid, or you're going through the muscle to get to a submucosal large fibroid, you are most likely destined for a C-section. And I'll lead with that, so people know that before we even talk about, before we even do the surgery.
Mm-hmm.
And also say, Roscoe, my doctor informed me that she would not let me go to 40 weeks, that it would probably be scheduled at 39 weeks, and to expect after 36 weeks that the baby could come at any time. But her whole thing was, we don't want your uterus contracting.
Yeah.
And so the 40 weeks was never really an option. And in fact, my daughter was due on September 29th, and she was born on September 9th. So she came early. But I definitely understand your concerns with the C-section. I can say my recovery wasn't bad, and I think that C-sections get a bad rap. It's different, but you have a healthy baby, and that's really all that matters. Okay, next question. Do the doctors here recommend the use of Zoladex or any other GnRH analogs, my experience with them was not good. And I'm not familiar with that.
So those are medications that typically suppress our estrogen levels and almost create an almost menopausal state. So you're basically cutting down that blood supply, food supply to the fibroids. And typically some physicians will use it in order to shrink the size of the fibroids and be able to address more of them in a surgery without maybe potentially causing less damage to the surrounding muscle. I think it's a little bit surgeon preference. Tiffany, I'd be curious to know how you would approach it. I don't myself personally use GnRH analogs. I find that they are difficult to tolerate and often a little bit torturous for a few weeks before the surgery. Some of them have like a flare response where you have a couple of weeks of terrible bleeding and bloating and menopausal symptoms and all that kind of stuff before you go into surgery. I haven't found that not using them has limited me in surgical approach much at all. But that's my experience, and my training didn't really involve using GnRH analogs. I don't know about yours.
Yeah, so I did use them a lot in training. One, for women who are older, who may be close to menopause, we would maybe bridge them to menopause using GnRH agonists or antagonists. And they work quite well when you're trying to treat a certain symptom like bleeding. When you're doing it perioperatively, so leading up to surgery, where I have a 9-centimeter fibroid and I think I'm going to shrink it so that I can do a pretty little incision instead of a big old incision, it might take about 3 to 6 months, and really you see maximal decrease in size at 3 months, but it doesn't work for everyone. The side effects can be intolerable, and some of them I can't, once I give you the medication, it's like a depot shot. It lasts in your system for 3 months. There's not a lot I can do to help mitigate those new symptoms. Like first you're bleeding to death, now you're having hot flashes, you want to take your clothes off. It's just like, out of the frying pan into the fire. So I personally, because I am in fertility solely right now, I don't use them for that. Fertility, we're trying to move things along as quick as we can. So having someone be on a medication for 3 months before we even get to a surgery, it typically isn't necessary. And the amount of volume that a fibroid goes, so if we say a 9-centimeter fibroid, it might go from 9 to 8.5. And that's a tremendous decrease in volume for the fibroid, but for me, it's not going to make a lot of difference surgically. So some people use it quite frequently, but again, I think you also have to know what you're treating, what you're trying to do, and surgically, some people use it too, but the length of time might be a little bit much for some.
Okay, last question before I have to wrap this up. Can pedunculated fibroids be removed at the same time as childbirth, I guess after your labor? And really, I'll just open that up to, can you remove fibroids? I mean, if you're already in there and I've had a C-section, can you remove the fibroids after you take the baby out, or is that just way too much happening?
Well, I don't deliver babies anymore, but I will tell you, back in the day when I did, we absolutely did not remove them at the time of a C-section. So you couldn't do it at a time of vaginal delivery. There's no access. But if you have the uterus there and you have a little pedunculated fibroid, you probably could. It has a thin stalk, one little blood supply, so you just take it out. But if I have a fibroid that's embedded in the muscle, guess where most of the blood supply in your body is going during pregnancy? It's going to the baby. So why would I want to open up this uterus even more in a contractile portion and have blood rushing through a new incision that really isn't necessary and potentially causing something catastrophic? It's really not worth it. You might think like, oh, one and done, one surgery and done. But I think looking at the risk for it, most people would really not do that.
Yeah, I agree. That's still, again, same thing. I don't deliver right now either, but that was the general consensus in general. You have a flood of extra fluid in your body, you have extra blood in your body. Your uterus is already stretched out. Its anatomy is not normal at the time of delivery. You've just gotten baby out. Your primary concern is getting that uterus closed, getting that bleeding stopped, getting out of there. for mom's health at that point, right? So going after fibroids, unless they are preventing you from getting baby out at that time because they're in your way or something, we don't typically tackle them at the same time. It's not usually a smart idea.
So the only thing coming out is the baby and the placenta and everything else.
Pedunculate, I agree. Like if you could snip a little pedunculated one off that happens to be hanging around or something, maybe. But even then, I don't.
Yeah, even then your heart's beaten because if something goes wrong, you really can't, you don't have a leg to stand on of Dr. Jones, why did you do it at the time of a C-section? And then the patient lost their uterus. It's like, it was right there. No.
Yeah.
So.
Okay, so before we wrap this up and toss it over to Kim, I just want the doctors and Roscoe to give some advice to the people who are listening in on Zoom in terms of how to advocate for yourself when you go to the doctor and you have the big obvious symptom, I'm bleeding through my clothes. What are the other things that maybe you should track leading up to the appointment? Like, oh, I've been peeing a whole lot more than I see, my friends pee, or et cetera. What are the things that you should be thinking about and tracking? And then when you get to the doctor's office, what should you be asking? And how should you really be advocating for yourself?
I think that you should track any changes. Right? If there's something that is, some things are very insidious, they just change slightly over time, you really don't feel them. And unfortunately, that's a lot of times with fibroids because they grow so slowly in most people. But, when I talk to people, it's like, oh, when my periods first started, it was like this. And then there's these drastic changes. Yeah, you should think about that. If you're having pain with sex, if you're feeling bloated, if you're feeling things in your abdomen that are, like harder and it just doesn't make any sense. Of course, we talked about changes in your bowel movements, frequency of urination, anemia, those things, just, think about it, like what's going on. And then when you see your doctor, make them get an ultrasound. Don't let anybody do a bimanual exam, which is like when they put their fingers in the vagina and then tap on your little tummy and, say everything feels good. Because truly, most of the time, you don't feel anything. Mm-hmm. And then, a speculum exam, doing a pap smear, you're not going to see anything. I really think we should be pushing, if you're having symptoms, an ultrasound is warranted. It just is warranted. So I don't know how these people escape their doctor without a basic ultrasound to look at the uterus and make sure that things are okay. So that's what I would say. Educate yourself and advocate for yourself. Sometimes you have to know the workup because your doctor don't. So that's my advice.
Yeah, I'd say advocating for yourself is number one. So whatever information you can know about your own body, it's your body. You know it. You know your cycle. If you're paying attention and you're noticing these changes, this is different to you. This is affecting your quality of life. This is affecting your sex life. This is affecting your, exercise, whatever it might be. You have to be able to convey that, right? So I can ask probing questions, and maybe I do more because I see more, but I also, it's a shared relationship. I can only do so much from what you tell me. So tracking cycles, I think all women should be tracking their cycles. It's so easy now. You have an app, you put it in, start of your period, end of your period, how many, be able to answer how many pads you go through on your heaviest day, other kinds of symptoms like we just talked about, and be able to convey all that information. I agree with you, Tiffany. I have no idea how these women end up without ultrasounds. It's so easy. There's zero radiation involved. It's a bonus that you just get so much information from an ultrasound. It should either be done in the doctor's office or get sent for one. That should be number one thing. You have some cyclic symptoms with your cycle, then definitely that should be the case. And if any of those symptoms are going on, honestly, no one should tell you that it's not enough of a problem. And that's another thing. Like I've had women come and say, well, I wasn't bleeding heavy. Like you mentioned, bleeding wasn't really my problem. I was kind of asymptomatic. Okay. I was like, well, what else does that mean? I'm looking at this woman, her uterus is reaching her above her belly button. She looks like she's 8 months pregnant. And then I ask her about all these other symptoms. Oh yeah, it puts pressure on my bladder. I can't have sex because of it. I can't do this, but I wasn't bleeding heavily. I'm not anemic. So they said I didn't need to do anything about it. It's affecting your daily life. It's affecting everything else in your life. Yes, you can do something about it. Yes, you should find someone who's going to listen to you and help you do something about it because it's that important. So I can't, say more about advocating. And I think, finding the doctor that's going to actually hear you out, not dismiss your concerns, actually help you kind of come to terms with them and figure out what's the root cause.
And not just give you OCPs or oral contraception pills, okay? If they just send you out with birth control pills, get a second opinion.
No, I mean, like we chuckle at that, but honestly, I feel like that is the, heavy bleeding, birth control. And like, that's the go-to for some reason. And, I completely agree with you. I'll just jump in real quick because you mentioned Dr. Jones about getting the ultrasound. And I know ever since I've been diagnosed with fibroids, I go to my, OBGYN. I move a lot for my job, and I go to the OBGYN and I say, look, I've had this issue. I will be here annually despite whatever my insurance says. So put in whatever code you need to put in, but watch this because it's an issue and fibroids can come back. And I want an ultrasound with my pap smear, period. And I found doctors who are more than willing. So I think I've just been lucky with that, because I do know doctors who are like, well, no, it's not any time off your back. It's not any money out of your pocket. So let's just do it and get it done. So
in their defense, I was just going to say, in their defense, I think we have to change training, because as Dr. Shyama and I were trained not to do them. They're not indicated. And it just makes no sense now that I'm grown and out of baby med school and training. It makes no sense why they're not indicated when this is a burden that most women, especially Black women, maybe that's why it's not indicated, will face.
No, and you're absolutely right about that. So then, Rosco, just in hindsight, what advice would you give for people in terms of advocating for themselves? Because you dealt with this for 8 years.
I mean, y'all have said everything already. I'm so grateful that everybody gets to hear your words of wisdom, but ask for an ultrasound and ask for an ultrasound and ask for an ultrasound, and stop thinking that you have to be so strong. Like, women, we are actually crazy when it comes to that. Like, walking around with your hemoglobin so low and almost passing out and being like, oh, I'll just wear 2 pads this day and put on 2 pairs of panties and leggings under my jeans. Stop doing that. It's literally ridiculous. We do not have to be so strong. So take care of your bodies, ask questions, do your own research, pull up to these doctors and say, listen, I need my ultrasound. This is not normal. I don't want birth control. Just really listen to your body and take care of your body. And if one doctor is not taking care of you, you have to see someone else.
I completely agree. I don't see anything wrong with getting a second opinion, and sometimes a third. And
fourth or fifth.
Right. And sometimes it's not even that, I don't trust the doctor I went to. It's just, I didn't like you. Yeah. Like, you just weren't nice, or you weren't listening, or you know what I mean? Like, we didn't vibe. So on to the next. Okay. With that, I am wrapping this up. Tanika should be so proud of me, girl. I finished on time for once. So that is it for me. It's always a pleasure doing these panels and talking and being open and sharing stories and helping other people out, because I think that we do, as women, as we've said, endure to the death of us, and we are very silent, and it's always the next woman sitting next to you who's like, oh yeah, I've had that issue too. And if we talk more, we can help each other out. So Dr. Jones, Dr. Matthews, Rosco, thank you so much for being here tonight and sharing your stories and sharing your expertise for free. It is so great. Thank you kindly. And I think because Tanika is a little bit swollen because of that dental work, I'll be passing it over to Kim. So take it away.
Thank you so much, first Adrianna and Nikki, for your continued support of this organization. We couldn't have done this without you, so we thank you so very much. And to the lovely guests, Dr. Matthews, Dr. Jones, thank you so much for imparting your wisdom and your advice upon us. Self-advocacy is key. That's what we are always emphasizing. That's what we're always preaching, that it's so important for you to be your own health advocate, because nobody knows your body better than you. And just to add to what everybody's been saying, I think it's also important to remember, because it can be intimidating to go to the doctor. So I think it's just really important to remember that the doctors need to hold our expertise over our own body in higher or equal regard to your expertise as physicians. So I just wanted to emphasize that. And to Rosco, First, congratulations on your wedding. I know there's other places that you can be, like with your husband, rather than being here. So thank you so much for, taking the time out of your schedule to be here, and your vulnerability, sharing your story. We know that sharing our stories is healing, it's liberating, it's empowering, it helps to break down the walls of silence around this condition. So thank you so much, Rosco.
Yes,
And to all of the attendees, I hope you're as empowered as I am. These past 3 days have been truly rewarding. And we're going to continue. Although this is the third and last evening of this particular series, we're going to continue programming. We're going to continue connecting you with doctors and resources and other women who are struggling with fibroids. And that was the reason, this platform was created, to foster community, because we're all shared. We're all united through shared experiences, through shared vision, and through a shared mission. So we're going to continue creating these safe spaces for all of you to be able to share your stories and continue advocating for yourselves and for each other. And these are our social media handles. Please follow us, connect with us, reach out to us. We're here to support. In addition, like I mentioned, we want to continue bringing you this programming. So if you want to donate, please do go to the link in our bio on Instagram to donate, and visit our website, visit Facebook. And like I said, we're always here for you to support you. Thank you all so much for coming out tonight. And I hope you enjoy the rest of your evening.